the organizing committee for inviting us again. And as mentioned, we're going to talk about pelvic varices and which conditions would benefit most from treatment. When we look at the prevalence of pelvic varices in women, it's really not clearly defined. We know that it's rare in an oviparous woman, and the prevalence is on the high side in women with 2 or more pregnancies. But the correlation of the presence of pelvic varices and the presence of clinical symptoms is poorly understood. And the diagnostic and treatment standards for women with pelvic varices is poorly defined. Now, when you look at pelvic varices, most of the women will be asymptomatic, but they may present with different clinical scenarios. They either may have pelvic symptoms alone, which we'll discuss about in a little bit, and they'll present with pelvic congestion syndrome, or with lower extremity varicosities and symptoms, and some of them will present with a combination of both pelvic symptoms as well as lower extremity symptoms. Now, the ideal imaging and treatment paradigm should focus on the patient's dominant clinical symptoms. Making the diagnosis can be challenging. Usually the syndrome of pelvic congestion consists of chronic pelvic pain, which is pain non-cyclical, lasting more than 6 months, and their symptoms may worsen with standing, prolonged sitting. Usually at the end of the day, their symptoms are worse, obviously, from the prolonged standing. Dyspareunia may be present, or the symptoms may get worse during the beginning of their menses. In addition, other nonspecific symptoms may include depression, abdominal pelvic tenderness, dysmenorrhea, vulvar varices, back pain, rectal discomfort, or urinary frequency. Now, these symptoms, to make things more complicated, may overlap with other concomitant pathology and making the diagnosis challenging at times. And for all the physicians that are involved in the care of these patients, which they usually may present to either a gastroenterologist, a gynecologist, a general surgeon, or eventually may find themselves into your doorstep as a vascular specialist. So heightened awareness in all these specialties is required in order to make the diagnosis early on in these patients. So there's 2 different anatomic pathologies that may be present. The more common situation is reflux in the pelvis, whether it be in the ovarian vein or the internal iliac vein, or a combination of the 2. And there's some cases of pelvic compression, whether it be renal vein compression or iliac vein compression, as the underlying pathology. When you divide the reflux in the pelvis, it may be divided into 2 components: the super component, which is a superior component, which involves the ovarian vein broad ligament, or the inferior component with extension of the reflux down to the lower extremities. From the clinical experience than really data, usually the patients who have isolated pelvic reflux and with no exit points into the pelvis present predominantly with pelvic symptoms, and those who have exit points into the lower extremities with reflux, they usually present with non-saphenous varicosities and lower extremity symptoms. Now, having said that, we do have patients with both combination of both going on, both in the pelvis and the lower extremities. The treatment can include medical, surgical, but these days most of the patients we manage are through transcatheter embolization, and this is a perfect example here. Somebody with dilated left ovarian vein with pelvic varicosities, which is treated with injection sclerotherapy for the varicosities and then coil embolization of the ovarian vein. So really, which patients benefit from treatment? There's limited literature to look at this, but from a pelvic congestion standpoint, a patient with pelvic symptoms, we need to first exclude other pathology. Having done this, complete or partial symptom improvement can occur anywhere from 70 to 100% of the patients with improvement in their vision and/or pain score after treatment. And here you can see most of the improvement is seen in patients with embolization when compared to hysterectomy and oophorectomy. Now, having said that, again, a significant number of patients, up to 30%, will not have relief in their symptoms after treatment, and this can be due to several reasons, whether it's other causes of the patient's symptoms or inconsistency in treatment, treating the entire pelvic source of the pathology. Now, in patients with lower extremity symptoms, the data for this is even more scarce. as far as improvement in symptoms. And then I would divide this in two groups of patients: those who have primary non-saphenous varicosities, who come for the first treatment, never had any treatment of the varicose veins, and they're pelvic in source, and predominantly their symptoms are only lower extremity symptoms. The role here for treating the pelvis first, I think, is questionable. And then you have the group of patients who have come back with recurrent varicosities and symptoms after several treatments, and the source again is the pelvis. And will treating the pelvis in either of these groups decrease recurrence is unknown. This is the most recent, actually the only paper I can find on pelvic embolization as far as improving lower extremity symptoms. They found, this was published actually last month, in March of this year, that embolization of the pelvis improved lower extremity varicosities in about half the patients. Now in those patients, about 80% of them needed a treatment of their lower extremity, so they needed additional treatment despite after the pelvic treatment. But they found that treating the pelvis first allowed switching strategy from surgery to sclerosis. And again, this is, I'm not sure how strong this is as far as the data. So in summary, pelvic varices is common, especially in multiparous women. In women who have obvious pelvic congestion syndrome with classic clinical symptoms, have significant improvement after treatment of their pelvis. In those who have lower extremity varicosities, I think there is a role in women who have recurrent symptoms and recurrent varicose veins. I'm not quite sure what the role of pelvic treatment as a first-line therapy in those with primary lower extremity varicose veins. So no previous treatment. Thank you.